So good afternoon, everyone. I'm Sofia Palmieri, and I have the pleasure to welcome you in this session this afternoon about AI and data quality. With us today, we have amazing speakers. I'm really excited because I really want to learn from all of them. So let's start with the first speaker that she's going to present online. She's Karolina Mackiewicz, and she is Innovation Director at the European Connected Health Alliance, and she has over 12 years of experience in international projects over e-health. So I think she's gonna give us an overview about what we have to consider AI community when we want to answer the leading question of today, that is, can the AI community self-determine minimum data quality standards for AI training below which the data is unsafe to be used? So I think, Karolina, if you can hear us.
Yes, I can hear you. Thank you. Thank you, Sofia, very much for the introduction. Good afternoon, everyone. Bom dia. I'm sorry that I'm not with you in a beautiful Porto. I'm joining you from Sub-Zero Helsinki today, this afternoon, and I'm pleased to be part of this fantastic and insightful session on the health data quality, a dynamic complexity. And as Sofia mentioned already, that then I will try to answer the question on I think that one of the guiding questions for this session is if the AI community can self-determine the standards for the AI safety and security, and I will touch on this in this short presentation. Yes, I'm Karolina Mackiewicz. I'm from the European Connected Health Alliance, and at the beginning, I would like to tell you a couple of words about the organization, because this is actually the starting point for my take on this topic of the AI safety standards and data quality. So some of you might know us, the ECHAlliance or European Connected Health Alliance. We're the global connector for digital health, going way beyond Europe. And we are actually bringing together community of the digital health experts, knowledge from expert groups, thematic innovation ecosystems, and also the innovation generated through the projects that promote global health transformation. And one of our key elements of our work are those need-based digital health ecosystems that bring together a permanent community of stakeholders to develop a joint health agenda, aiming to address and find common solutions to regional health challenges. This is, and I hope you can see in the circle, and I'm sure that many of you, of course, know this multi-stakeholder ecosystem thinking or approach, where of course we try to bring together as many stakeholders as possible, because they all play a role in making sure that the digital health solutions that are being developed make actually sense, respond to the needs, are safe, secure, effective, efficient, and actually serve the purpose. And there is also the way to that the regions can uptake them and bring them to the healthcare system. So in our view, and I think this is the general there is the general agreement that those multi-stakeholder ecosystem break down silos and help transform healthcare delivery. So, and also, as I mentioned, we have the number of the international projects. There are some of them listed here, but I wanted just to raise your attention to those three here: Gravitate Health, Value Care, and Brain Teaser. You might read more about them on the website. It's not the point of this presentation, but they actually work on the, I mean, you all know that there is plenty of course different research and innovation, research and development projects that deal with the AI, build the different solutions that are AI based, and those 3 projects, they are very different in the scope. So brain teaser is actually about the multiple sclerosis, value care about the value-based care, gravitate health is about the medical health information, but they all develop the solution that is AI powered. So here also some lessons that I will bring in this presentation, and then later in the discussion also come from the experience from those projects. And I wanted to, of course, also highlight some opportunities that I see in AI in healthcare. So of course, and also in this interplay between the AI and better quality data, but also better quality data powering AI. So of course, those opportunities is like better data and then better services, and because of that, better treatment. But of course, on the risk, I try to be very minimalistic and thinking really like the key core risk is that, well, wrong data, of course, or bias in the data, and this is also something that I want to maybe stop for a second. That if we think about the data quality or lack of proper data. We recently, 1 month ago at the Digital Health Society Summit, I led the session on the gender bias in and data quality. And I was surprised how actually little data on or from women, or how little the women are actually being included in the clinical trials, how little we actually know about the different solutions and different medications and treatments, how they actually how women respond to them, because they simply were not included in those examinations or tests and validations decades or even years ago. And of course, there are also different sexes, that different genders that are not being often, or that are being ignored. And so this is what I really would like to stress here, just the biases. And of course, we don't have to be, we cannot imagine that there is zero bias, but let's also remember that we should strive for the best quality data. And then of course, lack of uptake. So here maybe this is not so much related to the data, but of course, if we have lack of uptake of the solutions, then we have less data than the data is of poor quality, and actually then we are in this vicious circle. And obviously the privacy and security issues, and I think that here also this relates to the policies and the regulations that sometimes might not come along with the development. So we of course observe that the developments go faster than the policymakers realize that there is an issue. So of course, I would like us all to keep remembering about this whole community approach. So when the question is like, can the AI community self-determine or regulate the standards? I think that in the first moment when I think about AI community, I don't know what you think, but when I started to think, it was like about the IT developers, about the data experts, like generally people who deal with technology and data. And my take would be here that we have to go beyond that the community is actually wider than those people who develop it. And in the center, it's always the patient and citizen. So we definitely need to empower, inform, validate, and teach. And of course, the very easy tools to do that is to engage those people in co-creation, develop personas, for example, to understand who are really our clients, and applied end user perspective. And also small anecdote to share here. I was on Tuesday at the EU Health Summit in Brussels, and there was a lot of talking about the, as you can see maybe here, about the patient-centered approach, right? Patient-centered approach as a key or central approach for the delivery of accessible and affordable health innovations. And there was, of course, a lot of also advocacy for putting ourselves in the shoes of the patient to better understand their perspective. And then I also started to think why it's so difficult for us to put ourselves in the shoes of the patients if actually we all are patients at some point of the healthcare services or system. Or we know someone currently, someone close from us is probably currently, unfortunately, a client of the healthcare system. So somehow this, I don't know, maybe we can also discuss this with you today. Somehow it bothers me why we have to advocate for the patient-centered approach. We are all patients. So why when we develop those solutions, why we really cannot think like, what I would like to get from this as the end user, or my mother or my grandmother of my brother who has nothing to do, for example, with health data. So I think that this is from me. So short message about that the community starts from the patients and citizens, and we have
I'm
to
so glad,
include them. Thank you so much for getting me a chance to voice that.
So glad that you stick to the time. I was worried to interrupt you before the end of your speech, but this was not the case. So I think in a democratic way we can decide that the questions will be posed only at the end, right? Or do you already want to share some questions to Karolina? No, we can wait until the end of the session. Okay, then we welcome our second speaker, that is Gordon Johnston. He's the leader at Johnson&Johnson Technology and is here to help us to dive into an industry perspective, since, as Jens said before this morning at the keynote speech, the beginning of the day, quality of data is really complex dynamics, and we really want to give voice to every perspective. So thank you, Gordon. If you want to show your slides. Okay. Yes, I think.
There's only 3 slides, guys. Hi guys, I thought I'd just leave this up, okay? You can decide after I finish speaking if I have any credibility. But, that's basically just to give you the background. The main reason for giving you the background is that I've got to say that thing at the bottom. I work for Johnson&Johnson, but unless I'm giving a presentation about Johnson&Johnson affiliates or products, I speak as my own personal point of view. Okay, then you think, well, what makes you special? Well, I'm active in Digital Europe and MedTech Europe, and the ECHAlliance. You may be familiar with these organizations. As far as Digital Europe is concerned, they have an e-health working group, so I get to play in that from time to time. MedTech Europe actually has a very specific artificial intelligence working group, and as those of you might know about the ECHAlliance, that's focused on in silico medicine, clinical trials with computational medicine, computational modeling, and also digital twins as well. Okay, so what I'm going to try and do is, when I got asked this question, and I thought in 3 parts. I thought of the can word, can we? The next thing I thought about was, what do we mean by the community? And the next thing was self-determination. And I still don't know the answer to it from a yes or no perspective. You have to decide that for yourself. The way I look at it, and you're gonna think this is a bit of a cop-out or me making an excuse, but generally the conversation is very use case based. And it largely has to be, because it has to start and end in the clinical space with which you're talking about. Okay, the data comes from there, and then some drug that you've discovered using the data, or some medical device that you've developed using the data, or some software as a medical device that you've created an artificial intelligence model for, has to go back into that clinical space and ultimately say whether it's a yes or a no. I agree with everything that Karolina said, everything she said from an ethical perspective, because the ethics of it doesn't go away. But if any of you are familiar with an ethical conversation, it's not one dimension, it's not even 2 dimensional, it's multi-dimensional. There's lots of reasons why we don't do things, and particularly from a medical situation. Okay, so what I'm going to try and do is try and elaborate a little when there's two words that Jensen Clark mentioned this morning, which is, dynamic complexity, because that's the reality of it. It's not a static conversation. Sometimes you only have the data that's available to work on, but you may have a pressing need for an unmet clinical scenario. Okay, and even if we just focus on the data and the models, and what I'm going to do is I'm going to focus on the data and the models, then I'm going to focus on the people aspect, and then I'm going to finish off by focusing on what I consider to be, that kind of wider conversation when you're deciding about whether data is safe or not safe. And you probably heard me mention that in my kind of comment to Marcus on the European health data space, that the data that we ultimately use for creating models and analysing healthcare spaces can be far removed from the real world raw data or the randomized clinical trial data that we collect. Okay, so it's not just a case of taking, somebody's health record and throwing it into a model. Okay, if you take CT scans, for instance, right? CT scans for cancer tumors, we want to get radiomics data, right? But radiomics data can be up to 1,000 features that we take from a single CT scan of a person's cancer tumor, right? That could be all kinds of forms of data, very, very complicated. So not only do you transform that data, but you also take the data away from the people who understood that data in the first place. So there's a whole AI literacy conversation to be had as well. I'm all for what Yannis said in terms of bringing people together from different parts of the kind of supply chain, if you like. But you have to let them have conversations at a level that's understandable to them. I mean, there's no point in me putting a data scientist in front of a patient, because that data scientist is probably a mathematician at heart, right? It's not used to having informed consent conversations with patients. But if you think about all of the different things, training data that best represents the intended use, who gets to decide that? Well, it starts with, a clinical specialist. I don't know anything about most clinical procedures, at a level of practice. We're relying on somebody saying, yeah, the genuine material covers the wide population, so on and so forth. You maybe hear of federated data networks that are arising all the time. The idea of federated data networks is that you let somebody else take care of the anonymization. You let somebody else take care of bias by collecting data from multiple sources, anonymizing it. Oh, sorry, you need to go back. Oh, dear me. Right, now we'll go back to the summary. And the reason I'm not talking to every single one of these data points, these are all the things you have to think about. Just when you're thinking about the data itself and the model that you produce from the data, right? And every single one of these conversations is a multi-person discussion. It's a multi-person discussion. You want to use a piece of software to tell whether somebody has cancer or not, but you can't prove that software in a clinical trial unless you use biopsies to confirm it. And that might mean doing biopsies on perfectly healthy people. Okay, so there's an ethical question there, right? So there's all kind of you'll false negatives and false positives from software, just as you have from a physical trial. Most of us have got used to lateral flow tests over the last couple of years, right? They come into service with a recognized false positive rate and a recognized false negative rate, or specificity and sensitivity. Software is no different. Comes under the same kind of rule. You either diagnose something correctly or you don't. Okay, so even if you want to bring something in, it's not going to be 100% effective. It's going to have some level of error, and you have to have an ethical acceptance of that in the clinical space. There's a lot of what's become very, very prevalent, and a lot of clinicians are getting used to this. But if you bring something in that's digital, one of the benchmarks is that it has to be better than the human beings that you're replacing. Now, if you think about an airline pilot, they're probably 99.9999% effective. But if you look at a dentist who's trying to detect mouth cancer, believe it or not, the rate of effectiveness for a dentist detecting mouth cancer in the UK is 42%. It's one of the things that we're expected to do, but they're not very good at doing it because, you know, it's not their speciality. If I can move on, this is a really nice paper that my colleague Nigel Hughes, who's here, one of the keynote speakers, who's co-authored with Nathan here. And aside from talking about federated networks and using clinical research data at scale, what it does is a really good job of articulating all of the different stakeholders. You know, you've got people here, a lot of people put their health data on Facebook. I have a family member who probably puts more about her on Facebook than she does when she's talking with doctor. Okay, that's the reality. There are actually health record systems emerging where patients are able to add to official health records. They're able to add their own opinion, where a doctor will say, this person is such and such, and the person is at liberty to say, I would agree with what my doctor said, or this is what I think I have this condition, and my doctor says I don't. So, you know, that's something to bear in mind. You've got effective sharing between healthcare providers. You know, effective sharing between healthcare providers, and that's an interoperability challenge in itself. You know, because what you'd like in an ideal world is for specialists to be able to exchange data with each other, not necessarily hospitals. You know, which is enough of a challenge, but really what we're looking for is for specialists. The specialists do data between themselves today, but they should do it by email or Zoom call. Right. But ultimately, the value is collecting that data. Otherwise, it just disappears in the ether. And obviously, you know, in an ideal world, when industry starts looking at possible data for research and development, it wants to involve patients because it's going to come back to patients anyway in a clinical trial. So that in an ideal world, to grow literacy and to build trust, you want to involve patients in the beginning. When it comes to physical drug manufacture, like traditional physical device manufacture traditional, there's no value or less value in taking human beings into the manufacturing process because it's so fragmented and you know, so complicated. But when it comes to technology, once we believe in a piece of technology, we buy it at 100%, right? Everybody knows that. We all got phones, we all watch Netflix, you know, we all trust our phones, we all trust Netflix. So the key is making sure that not all of these conversations are at an expert level and not all of these conversations are at a one-on-one level. Open for these conversations to be had. You create mechanisms for people to connect. That's what I'm hoping for from the European Health Data Space. The first thing I'm hoping for from that is it doesn't set the hurdles too high, which you might have heard me articulating when Mark was talking, but that it seeks to do the basics, which is it just gets people to connect with each other. There's nobody who doesn't want a European Health Data Space, but we have to be careful that we don't make it an impossible thing to sustain and work with them, primarily to work with them. Okay. And the last slide is a couple of things are hidden, but this is the thing, when you have data, it's not just that this data is a gold standard from a clinical perspective, because it's a life cycle conversation. A life cycle conversation. You know, you've got to have context, right? Okay, the data is only meaningful in a specific context. Okay, it's not a gold standard data set, and it's a gold standard data set forevermore for everything. It has to have context. How do you assure that? How do I know the hospital how do I know the surgeon who entered that data is professionally credible? How do I know the hospital is a hospital of good standard? How do I know the company who anonymized that data has all the right security practices, the right privacy practices? How do we assure that practically? There's only so many questions you're allowed to ask. You can't just come up at a hospital and say, I want an interview with a surgeon because I want to know where that data comes from. I want to know that, it has a professional issues, etc., etc. There's a lot of things that you have to take on a risk-based approach. Okay, obviously security is massive, but the challenge with machine learning is it's added additional threat vectors. You know, you can play with the data set, you can alter the parameters of a trained model. And when I talk about playing with the data set, I don't mean turning it from apples into oranges. The danger is really, really subtle preparations that you play with that false positive and false negative. Okay, that's the theory part, that you change it so that it's very difficult to notice that you change it. But it's enough to take a device from an accepted position to an unacceptable position. So again, you know, security introduces new threat vectors. Ethics and communication, you can put those two together. We're very patient-centered. There's lots of situations where we do something under certain ethical circumstances that we wouldn't do under other ethical circumstances. COVID is a good example. Look how many vaccines got approved for emergency use without recognized amount of safety data over a recognized period. Okay, so there'll be lots of situations in the future because of very clever technical advancements. A particular doctor and a particular patient will say, yes, I'll accept the use of that. So, you know, you be careful that the ethical side of it is seen as a multi-dimensional conversation as well. Communication, that's that whole thing on the previous slide. You've got to give people enough information that you make it clear to them that something is worthwhile and credible, but not too much information that you tip them into that, you know, I'm being bamboozled here. I'm being sold a duck, as you say it's called, right? But and obviously systems and processes, you know, the things that we do to make data available, the things that we do to collect it, the things that we do to process it, the things that we do to, you know, give it a description, the way that we ideally there's lots of things that we would want to automate, there's lots of things that we would want breakpoints that human beings get involved. It's a question of balance. You're always going to have regulation, but you're also going to have innovation in the state of the art. And you've got to allow for that balanced conversation as well. Relevance, you know, that's data can be safe, but it can be useless. Okay, data can be of no harm fundamentally, but it can also give you a device, for software as a medical device that, you know, not clinically effective. Complexity, you know, trust was kind of covered. Metadata is a huge thing for data sets and machine learning because one of the things we have to guarantee from a regulatory perspective is that training data and test data never cross over, never bleed into each other. And that means version control for data sets. Now, if any of your software developers have anything to do with software development, you use the branchings and version control of software. Now, you're going to have to start learning into the same experience for data set. Because somebody's going to want to tweak or recalibrate the data set for all the right reasons, and you have to be able to have a record. You have to be able to demonstrate where a data set came from, how it started, and what its change history is. And you're also going to have to pair it with the models that you create. So you're pairing data with software. So again, it brings lots of things. And metadata is very complicated. You've got metadata that describes a data set. You've got metadata which tells you the change history of a data set. And you've also got metadata to tell you where a data set is or should be. Right? Where should it go? Okay. Time, you know, a use by date, shelf life. You know, you might have data which is considered a gold standard, but it might be data that was collected on a retired surgical procedure. Okay, or you know, with a device or devices that, you know, are no longer in service. So these are things to consider as well. That you may put a shelf life on a data set. That doesn't mean you get rid of it, but it means you stop using it practically. And then there's reality. You've always got, you know, what something can deliver versus expectation. And this is the challenge that a lot of digital health technologies have. You know, you always want your phone to work. You almost want the Netflix video, the Netflix film to go on as soon as you select it. Okay, so a lot of people have 100% perception with digital technology. And that's something that you know is going to be a challenge going forward, because you almost need a period of experience for all of these regulations to really mature and for the right standards to be developed. I mean, a concern that a lot of industry has is that there's a wave of regulations. The interplay between these regulations is yet to be understood. There's a lot of unintended consequences, which I'm sure will come. And there's also, because of these regulations coming in, there's a drive to create standards very quickly without that experience. You know, it's almost like you want a state-of-the-art conversation to be allowed to develop before all of these things come in. You know, is that really the case at this moment in time? Nobody's quite sure. We're all going in the right direction, but if you're thinking about the safety of data sets, you've got to think about all these things. And if you're thinking about an AI community, you've got to think about all of these things.
Gordon, may I ask you to wrap up?
Yeah.
Because we're running. Oh, great.
Yeah.
Sorry, I didn't want to be quiet. This is going to be for another night. Thank you. Then we have Nathan Lee, which is DPO and Information Governance Lead at EHD. And he was also working for the British National Health System, and he's especially into changing within governance systems such as GDPR, AI Act, and European Health Data Space. So I give you the floor and go ahead with your presentation. Thank you.
Thank you, Madam Chair. Thanks for the wonderful introduction. Good afternoon, everyone. It's a pleasure to speak to you this afternoon. And due to technical issues, you got me before Pedro, so I'm hoping that I will do him justice while we fix some technical issues. So I'm the Information Governance Lead at IHD and the Data Protection Officer. So I'm bringing something of a regulatory perspective here. But as Sofia mentioned, I did work for the NHS. I still have a relationship with the NHS, meaning the National Health Service, where I worked as an information governance manager for research. And what I need to do is draw upon my experiences of AI that we observed across the NHS Trust as this new technology started to rear itself. The facility became available to analyze data at some scale to look at predictive modeling across all kinds of areas. But when thinking about how we regulate and set standards for safety, I always go back to the context of medical practice. I'm not a practicing doctor or anything like that. I'm not a clinician. Wasn't trained to want to have a PhD in medical informatics, not medicine. But I always think of the second opinion idea, where an individual, given a diagnosis, always has the right to seek another view on the data and on the evidence that's presented the diagnosis to them. So thinking about how we start to think about setting a safety bar, this is the important question here around thinking around safety and data quality and what that means in context. So with the exam question, as they say for this session, now the technology failed again, so we'll just go old school. There we go. So that's the question that we've heard repeated this afternoon. Can the AI community self-determine minimum data quality standards for AI training below which the data is unsafe to use? I've got a big fat no there. So I'm going to be unequivocal, that's my position. I don't think they can. And it's not because they're not capable, they're not qualified, they don't have something to offer, anything like that. But I want to take us back to the context with which we're dealing when it comes down to it. Because even though the AI community is a huge part of it, they're not the only player here. We're thinking about healthcare interventions of some description, whether it's care, practice, research, any of those things. But thinking about the care provision paradigm, where does technology actually sit within the therapeutic relationship between the patient and their care team, their doctor, their nurses, their carers, and so forth? And we immediately go to some kind of diagnostic or medical intervention. And one of the big areas of interest for machine learning and artificial intelligence was looking at digital scans across different disease areas and pathology, where computers are very good at crunching large amounts of data and making inference about the findings within those scans and so forth. But it's not just there. And we'll recall as well, because this, a lot of this is in the public domain, so I'm not reaching any confidences as far as I know, but a lot of NHS trusts were thinking about how can we use AI to run the health service better. There's a great deal of interest in terms of prioritizing people for attending appointments, for example, so scheduling appointments and so forth. And several trusts looked at the possibility of saying, well, okay, given past experience, how likely is an individual going to actually show up to their appointment? Maybe they should get the appointment first if we've got to prioritize and so forth. Why don't we look at that? And that's all well and good. You want to make sure that your clinics are full and that people are there and they're more likely to show up. But then we are asking ourselves across the health service, well, why aren't people showing up for their appointments? You know, this is not a problem that AI has introduced, but it sheds another light on it. So what are the reasons they're not showing up? And if we're going to make someone wait an extra week or month or these days 6 months, given the backlog that we're experiencing across the UK and the rest of the world, quite frankly, you know, these questions are becoming much more important. So given these kinds of backlogs, is it right to be making people wait? And this is where we've got to think about data quality, because what were the evidence points that were being used to train the AI algorithms to make recommendations about who was more likely to attend or not? What were they looking at? Past attendance. Okay, fair enough. They came, they did not attend, you know, the evidence is there. But did the algorithms get a chance to look at why they didn't attend? Probably not, because with health service provision in terms of IT and technology and software, it's quite difficult to actually specify why someone did not attend. There'll be lots of DNAs, for example, did not attend. There may be a reason specified. It might be a drop-down list of pre-selected variables like was unwell or, you know, was busy or whatever. You know, it could be any of those things, or it might be free text. Okay, fine, we can have natural language processing free text, but is the data actually there? Probably not. Very often it's not there. We don't know why the person didn't attend. So when we get into a position where someone may not have been able to attend because they are a single parent, they had to pick up their children from school because one of them was sick, they had to cancel their appointment, how do we know that that experience was recorded? We don't, quite frankly. When we're talking about things like data quality, a lot of what we've been hearing over the last few days is around the completeness of that data, the representation of what actually happened. Because we only get a snapshot, don't we, very often in the clinical context. And when it comes to the research context and the training context, how much of that nuanced information is actually getting there? Can we be reliably sure of what's happening there? So, to what extent is the AI community aware of this problem? Maybe if they have some kind of clinical experience in practice, maybe not. But we have to accept that we don't know the whole story. So if we're going to train an intervention to make decisions or make recommendations at the very least around how this is working and what's happening, we have to make sure it has the full picture. And we can't reliably say that we're able to do that at the moment. So in thinking about setting those standards, when do things become unsafe, let alone unfair or unjustified, or indeed flipping it, not just unsafe, maybe dangerous. So if someone's not getting an appointment because the determination has been made by a computer program that wasn't well informed because the data quality wasn't up to speed, where do we find ourselves? So these are important questions we have to answer when thinking about standard data quality. And that will come from knowledge of clinical practice, of running health services, and from the patient perspective as well. I'm sure everyone as a patient has some kind of gripe because they got bumped from an appointment for some reason, because their hospital was too busy, they had to be moved and so forth. Why were they moved? What was the basis for deciding that? Did you ever get a straight answer? These are the kinds of things we need to think about when we're talking about data quality and minimum standards. So it's the capture of that information. So AI community is a huge part of this, but we have to work together and have a common discourse, an informed discussion and basis for proceeding. This isn't quite going to put that down. So with that in mind, We have a problem with the quality of the data in that it's missing, it could be inaccurate, it could have been lost or whatever, there could be damage, exactly. We've got all kinds of traditional data quality issues. But we've also got known challenges for artificial intelligence. Now, we've been through a lot of these already throughout the last day and a half of the tutorial yesterday and the speeches before. But some of these are obviously around data quality. They're screaming like, is the data accurate, for example? Yeah, that's a data quality issue out the bag. Is it safe? Well, that's a little bit divorced from the traditional view of quality, but at the same time, it's an important question. But then, is the data representative? Is another one. So if we're dealing with a hospital with a particular population, for example, are all the data points captured? Do they speak the local language, for example? Are they able to attend their appointments? Are we seeing what's happening within the care context and making sure the completion is there? But again, that goes back to a completion and representation issue within the data and its quality. So when we go back to things like, is it a societal good, is it explainable, those kinds of things, we also don't always immediately see the relevance of data quality there. Is it a societal good? Well, how do we know if it's a societal good if we collect no data on its impact, for example? How do we know if it was going to, when we're going to accidentally do something amazing on the back of breaching a regulation? And some of you may remember the issue in the UK in the Royal Free Hospital about the DeepMind intervention that was helping ward sisters manage patients with advanced urinary tract infections, for example. Now, they loved it, the nurses loved it, the doctors loved it, it all worked. It was really helping them to manage the patients. Unfortunately, there was a massive breach of data protection law because the trust had handed over millions of people's records to DeepMind to analyze. So this is all well documented in the commentary and the literature and so forth. So if you Google DeepMind Royal Free, you'll get all the ins and outs of how the Information Commissioner ruled on the case, but also some of the important points here, because actually I would argue the data quality concerns were actually minimized because the data was rich, it was understood in context, there were no major issues. But in terms of saying, well, there was societal good there because it improved people's care, there was a breach of law on the other hand. So that's something to bear in mind as well. But because we're short on time, I won't go through each of these and say this is why data quality matters, because I think that's an exercise, an ongoing conversation that we need to address moving forward. But the ethical considerations that Gordon was talking about before, and Karolina was talking about before, we've already touched on those. In terms of understanding the quality of that data that was used in the first place, things like individual autonomy and consent and so forth to participate. One thing that's dawned on me in the last 24 hours of being here is that I think it's a compelling argument to say, okay, I put it to you that under the context of an informed consent interaction with an individual and the use of their data, that data is of higher quality than cases where informed consent has not been sought. And here's why. First of all, the patient knows what they're consenting to, hopefully. The interaction is understood. The data capture is about that interaction. We know the context in which that data was captured. But if you're then looking at a series of anonymous records, for argument's sake, where we're not entirely clear where the data was captured, under what circumstances, what was the state of the patient, what was the state of the relationship in the context of acquisition of that data, we don't quite know whether the data that was represented is quite what we think it is. And we saw this yesterday in the workshop that I attended, where you could infer a lot about the Portuguese neonatal status from the data that's collected. But actually, it wasn't representing what was happening in practice. It was being skewed by factors like changes in policy around data collection, for example. And it was representing data for things like where people had their date of birth put in either at the beginning, the middle, or the end of the month, possibly because we didn't know, the data clerks didn't know when the day of the person's birth. They knew the month and the year, not the day, so we'll just put it in the birth. Those kinds of things creep in. So you can be assured that there's a lot more rigor when someone's consented to data capture in the first place. Now, I'm going to leave that with you for the moment. What I put together with these slides, we're not going through them now because of the previous talks, we've looked at a lot on things like the AI regulation and so forth. But moving forward, we have existing laws in broad terms. We have GDPR, which we all know and love. I won't go into that too much detail now. But we've also got things like medical device regulation and the CE marking and so forth that have a traditional approach to being able to quality seal medical devices and so forth. But within the AI context, we've also got, and I put these together obviously a few months ago, probably about 175 principles now, but across national interest and so forth, so across Europe, China, America, Middle East, they've all put together a whole series of ethical principles around the use of AI and so forth. And there are links in this slide that you can look at. And we've also got the standard research governance approaches around things like informed consent, ethics approval, and so forth to ensure the safety of trials and research interventions. But when we're looking at the safety bar for data quality in AI, we've got to look at the new regulations that are coming forward. So looking very briefly at this, there's the AI regulation, or the AI Act, as it's starting to be known as well. And this looks at the regulation of high-risk systems, of which health is one. There's education, power management across these and things like that. But health is a high-risk area that needs better regulation. And it's a huge push on competent authorities certifying medical interventions in effect for artificial intelligence. So we have to be able to make statements about the quality of the data, but we're not too sure what yet. We're going to be very quick, 30 seconds. Now, if you read down this list, a lot of this is about risk management. A lot of this goes directly to things like data quality and provability and so forth. But when it comes down to it, those are the kind of bars with which we must set our standards. But what it doesn't do is lay down the bare minimum when it comes down to it. This is what you must do, but we can't tell you how, in effect. You've got to figure that out for yourself with expertise and so forth. So in asking that question that we had at the beginning, can the AI community self-regulate for a minimum bar for safety in data quality? Well, not alone, but they can rely on other expertise in terms of how you set that baseline in context and then have it independently certified. So I'll leave these here for you as the kind of basis for what we might discover as those minimum, the basis on which we set those minimum standards. But the thing I think we've got to remember is that what we're learning is that it's not just about the accuracy of the data, clearly, it's about the availability of it and the completeness of it and understanding the context within which it was gathered. So I think we are certainly facing a brave new world in terms of how we regulate these things, but we have to be more open-minded about how we set standards around safety and how much trust we put in the data we receive. And my thought is that engaging people directly, either through an informed consent procedure or through a greater acknowledgement of how data is gathered, so gathering more data around the context within which care is delivered or self-managed by an individual, is vital to be able to say, okay, this data we're looking at is well covered and well established, knowing how it was gathered in the first place. So I'm going to shut up now because I've gone way over time. Thank you very much.
Okay, so everybody, we will start even without the slides, and in case we will integrate them while doing the presentation. So, so please.
Yeah.
Thank you. But people, I'm sorry.
I'll start.
Yes.
So thank you, Sofia, and it's a privilege to be here. So thanks for the invitation. I'm sorry for this. As you can see, there's an issue with the Microsoft technology solutions. But the idea, I'll try to add to our reflection and our discussion today. Just a concrete example coming from Microsoft. And trying to ask to the same question that we have here, is something that I will not put a no so clear as Nathan did. I'll say that there's a role to be played also by the AI community. So I think it's not against what you said, but it's something that is probably a different approach in that sense. Because as well, as already been said, this is really a complex situation with we should have a multi-approach, I would say, around this. At Microsoft, when we look at these issues, there's I would say, a thought around it, and it's clear. This is a quote from our president and our chief legal officer last week, that actually was in Portugal 2 weeks ago. And it has something here that says clear that we need to speed up somehow to face these challenges that we are living by now. It's clear for us, absolutely clear, that there are some issues, there are some complex issues, as I was saying, coming, and the use of AI, use of data can have severe damages and impact in our lives, and everything that has to do with us. We have some examples around that that we faced it before. These figures are coming from a report from Capgemini, and the interesting about this is basically what is top of mind for leadership or for managers, if you want, when regarding investments around AI and machine learning and so on. And what you can see there is that these kind of issues, like algorithms explainability, for instance, data security and privacy, these kind of issues are nowadays top of mind. This same survey a few years ago or 2 years ago, you can say, the results were completely different. That sense, you probably have seen there something around scalability, around the performance, about easy to use tools and those kind of topics. Nowadays, these are top of mind for leaders. At Microsoft, we see that also the regulation, laws, standards, everything that has to do with public authorities should be critical. And well, in the perfect world, let's put it that way. In the perfect world, we will have the right regulation to follow, and then to meet our targets also in this kind of topics like data quality, or if you want, ethics around AI. The point is that it is not. We are not there yet. There's no conditions. There's no information. There's no resources for public authorities to meet that goals by now. As already been said, there's a lot of things going on. Unfortunately, we have seen a lot in the last few years, and I think we are going to see in the next few years a lot of things around it. That's fantastic. But meanwhile, there's other things that we believe that we can do it, and that we can say the AI community can do it by itself. That will somehow have or complement what the regulation is doing. So we set some principles around AI for internal reasons. We've done this in 2018 already. Basically, there are 4 core principles that they are based in 2, we call it foundational principles, if you want, like transparency and accountability. What we have there is that well, very fast, I will go which one. Fairness, basically, I'll be very simple, sorry, but for for questions of time, I will be very fast on this. Fairness is, well, basically, we don't want anyone to be treated not in an equal way, so any kind of discrimination, bias, and so on. We know that that's an issue. That case that I showed around race is one of them. The other one, reliability and safety. Well, we know that trust is a prerequisite, I would say, when we're talking about this kind of solutions. So we need to build software applications, solutions that are reliable and that are safe. Otherwise, it's like in a car automobile industry, for instance. If you don't build a reliable and safe car, you probably get out of the market, and that's something that's happening also here. Privacy and security already been mentioned, of course. Everything that has to do with protecting our personal and private information is critical. We already have here the GDPR, for instance, but there's a lot more to do. Last but not least, in these 4 basic principles, I would say the inclusiveness, not only because we don't want to discriminate anyone, but also because we believe that there's a huge amount of people that can be more included if we use it correctly, the AI systems. We can estimate there's more than 1 billion people around the world with some sort of disabilities, for instance, that can be somehow, we can deal with it in a different way and include those people in a different way using AI solutions. Last but not least, transparency already have been said here by others. I think it's very important that everybody can understand how the algorithms work, where the data is collected and so on, those kind of things. I will not go deep on that. I think you all understand what I mean. Last but not least, the accountability. Because it's very important to understand who is the one that is in charge of the process or any stage of the process when you are building any kind of AI solutions. On top of it, we have now go a little bit on how we land these kind of principles. We have we call it the EFA committee, the AI Ethics and Effects in Engineering and Research Committee. Basically, it's a board of people that are divided in different working groups. You can see there some of the working groups. So that's people that are working directly on a daily basis on this kind of principles. There's also the Office of Responsible AI, the ORA, as we call it, where basically is the central hub where for what we call the Responsible AI project that we have internally. And then with a lot of, it takes care of a lot of different things. It's there. I'm not going also deep on it for. We have also a clear standard on that. It's divided in 3 parts. The first around governance, where we know which are the roles and the responsibilities for anyone. We can see how the procedures internally around the governance also. Second one, the requirements regarding concrete projects. We can see how we use it, the concepts and so on, and all the specific requirements. And the third part is around the guidance, where we can somehow try to land those principles in those concrete projects or initiatives or solutions that we are building. So landing this and putting it in practice, very simple. But we started with the principles, those 6 principles that are mentioned. Then we have the practices. You can see here there are some specific guidances or guidelines that we built in those kind of things, like the human-centric AI is our approach, then the conversational, the inclusiveness by design, fairness, and so on. Also some tools. I'll go into that in a minute. The governments, as I've mentioned, the Responsible AI Office, the committee, the chief officer, I would say, the handbook, and regarding the tooling, is something that I think probably interesting to share. We divided this in the understand, protect, and control into 3, I would say, stages or layers, if you want. And we are building this kind of solutions that are open also to all AI community, building our technology, but on open source also. And then, for instance, the interpretive machine learning or the fair learn, there are tools that can be used for developers from developers, or the developers can use these kind of tools to somehow build their own and assess, for instance, the fairness that tool fair learn is basically a way of assessment of the fairness of which solution that can be built. So basically what I'm trying to say is that we try in our way, to address these kind of topics, also internally, but also opening it to the community, and try somehow to play our part. We are completely sure that we will not address all the issues, that we will not have perfect data quality, just because of this. But I think there's a role also to be played by some of the community, or for the community with some of the players, and that's it. Last but not least, just this you can try to go a little bit deeper on this. This is open. I was thinking the link is there, but probably not. I thought it was. Okay, it's not clear here, but then we can share. There's some links that you can follow if you want, because as I was saying, this is open to everyone eventually to be inspired by what we are doing. I try to be as fast as possible. So thank you very much.
Well, I must apologize once again with Pedro for the technical problems, and thank you all for your attention and for your patience. and also to our speakers for the enriching and vibrant introduction and presentation. So thank you all, and I invite you to follow the next session in the auditorium. Thank you.